And we'll open this session for the question and answer period. We're just going to start. How about we start with the group here at the round table. If you do have a question, feel free to use the speaker, the microphone next to you. But why don't we start here? Yes.
Yeah, maybe more of a comment and then maybe just perspective. Our last presenter actually said something I think that's critically important, that's a little different than what we've heard at other times during the day. And most of our other presentations have focused, I think, on cardiometabolic types of health. And, you know, that's one perspective. But she said, I had more energy and my joints stopped hurting. And those are different measures than cardiometabolic health. So a person could have, you know, perfect cardiometabolic health but require a hip or a knee or some other kind of replacement somewhere down the road. And I think we need to just keep our eye on that ball, that it's not just cardiometabolic health when we're starting to think about excess weight and excess body fat and the pressure that puts on our skeletal muscle system. You know, I think that there's some data out there suggesting that people with low back pain have high degrees of obesity as well. And again, that's not cardiometabolic health. So I just want to thank the last speaker for kind of bringing that up and how important that is to our discussions here today.
And I think that was in reference to Dr. Caban-Martinez. Do you want to comment on that comment?
Yeah, absolutely. I wholeheartedly agree with the comment in that there are other aspects of body mass index that affect different organ systems, particularly musculoskeletal disorders. And we think about the worker landscape, individuals, adults that are obese and working that have manual material handling and are moving ache, right? Their low back and their neck with the load that is placed on the axial skeleton to do that work. And so I totally appreciate the comment from Faith in highlighting those aspects of her own lived experience, because it often goes beyond just cardio metabolic issues and looks at an individual's quality of life and how they perceive the work before them, as well as musculoskeletal systems.
Thank you. Joe.
Dr. Arterburn, you spoke a lot about utilization and estimates of utilization. You used some real world data from Kaiser on costs of those services, but do you have any real world data on what utilization actually looks like? I know you and I have done some work together, and I would guess that, you know, the utilization of bariatric surgery is way less than 5%. It's probably less than 1%, and the same with behavioral counseling. So are those 5% estimates even realistic, right? I mean, do you know from Kaiser what the utilization actually is of those services?
Yeah, Joe, thank you for your question. Yeah, it's 1 to 2% of Kaiser Permanente members that are eligible for bariatric metabolic surgery are currently undergoing it every year. So, but I think the treatment guidelines are encouraging, you know, broader use. I think, you know, the implications of the cost estimates I was providing were to consider what we would get if we were to be able to expand that. I think with patient preferences being where they are, it may be a difficult thing to move that needle very far above 1 to 2%. But if we could, you know, potentially get up to 5%, I think it's time will tell on whether that is the case.
Thank you, Dr. Arterburn. Yes. Dr. Yudowski.
Yeah. Hi, my question is also for David Arterburn, and that is, you talked about the very high costs of using, for example, obesity pharmacotherapy or doing some of these, you know, additional types of measurements. But you also talked about the increased costs of treating obesity, the medical care costs. So my question is, how can we get data on the impact of some of these treatments on those medical care costs?
Yeah, thank you for that question. So, you know, I think long-term longitudinal studies evaluating the impact on healthcare utilization and costs are needed to evaluate these. And in particular, we need the data from randomized trials. There are some observational studies that have been done that try to look at these questions, but most often we have to do some modeling assumptions about what happens to weight and weight-related comorbidities over time. We could use really good, high quality data about the rates of resolution and durability of improvements of weight-related health problems after drug therapy, after surgery, et cetera, in a randomized trial setting in order to better inform these kinds of modeling equations so that we can get a clear picture about what impact it has on cost. I think from a population health standpoint, we don't have the data we need to inform whether long-term healthcare costs are likely to be improved. Currently, it seems that the treatments themselves are likely to be cost effective. That is, they provide good value for money, but they don't necessarily lower healthcare costs to a degree at which they're reducing downstream comorbidities and the costs of care related to those comorbidities. So more research is needed, and perhaps focusing in on patients who have higher adiposity related risk with some of these measures that we've been talking about today could help us identify subpopulations of patients that are most likely to benefit from a metabolic or mechanical standpoint, as was being discussed. Thank you.
Thank you. Other questions from the roundtable? Yes.
My question is for Dr. Caban Martinez. When you were talking about the walking meetings, right, how do you balance that with issues of diversity and inclusion? So I'm thinking about people who have visible and invisible disabilities, as well as some of the cultural aspects of why particularly women who are expected to wear their hairs in certain styles may or may not feel comfortable working out or walking at work, quite frankly, in a very humid environment. When I speak as somebody with curly hair, I would not want to do that at work because I will come back looking crazy for the rest of the day. So how do you balance that and not create an environment where people don't feel welcome and invited in to the exercise process?
Yeah, it's a great question. And this is actually a frequent one that we get asked because folks try to understand, like, what is the utility of the walking meeting in and the first thing I tell them is not every team should probably engage in walking meeting, right? Not everything that we do or talk about is probably set to stand up and walk. And when trying to work with your peers on sort of that organization, that's the moment when setting the agenda and what is discussed in a walking meeting or not, conversations around what to do or not. I'll tell you, when we did those experiments here in Miami, it was during the wintertime, so it wasn't during the hot summer months, but conversations around how to let others know that you're in a walking meeting, because you could be walking outside, around a building and people come up to you and interrupt the four of you that are walking in conversation when you're trying to focus, dedicated 30 minutes. So I think the idea of identifying and discussing those conversations when the agenda comes up and what people feel comfortable with in terms of footwear, clothing that are appropriate for the attire are really important. I think in the goal is to be able to increase physical activity and for those teams to have those one-on-one conversations about what feels most comfortable for them to do that is how I would recommend.
Thank you. Why don't I shift gears and just remind the people who are watching online to submit questions. I will read one. I think this goes out perhaps to Dr. Erdeburn or others. How much does routine diabetes screening cost? When the cost of weight screening is discussed, it may lead to a discussion about weight bias and stigma, since the limits create barriers to effective obesity treatment. So maybe around diabetes screening costs, and actually, let me just ask something of my own about comparing drug costs in other disease states. So antihypertensives or anti-cholesterol medications. I'm curious about sort of other disease states and their costs as well. But first, the screening costs, David.
Yeah, screening costs for type 2 diabetes, just for identifying the condition of type 2 diabetes is typically diagnosed by the hemoglobin A1C measure, which is generally a cost of a test that's less than $100 per individual test. But the population health impact is that we're trying to screen as many people with a BMI over 30 and many people with BMI over 25, particularly if they have other metabolic related health conditions. So yeah, there's quite a large number of patients being screened by these. Certainly would exceed some of the cost estimates that I was showing today on the additional adiposity related measures. In terms of the various pharmacotherapy, treatment, there's wide variation in the cost of the pharmacotherapies that are available. Also wide variability in their impact on weight and other measures of metabolic health, but also lacking long-term health follow-up data on those pharmacotherapies that show reductions in incident cardiometabolic disease or incident reductions in mortality. So I think the antihypertensives, anti-dyslipidemic medications all have long-term randomized controlled trials showing reductions in cardiovascular events and mortality, which support their costs. There's wide variation, of course, in costs there as well. And certainly for pharmacotherapy for type 2 diabetes, the GLP-1s and SGLT2s are very expensive. And these medications are increasingly emphasized in the clinical practice guidelines, and cost of care for type 2 diabetes is escalating rapidly. So I think, the links between obesity, diabetes are really important for us to examine. It may be the type of population that going forward has the greatest potential for cost savings or cost impact, and that more studies are needed to show whether or not the advent of these newer, higher cost drugs leads to a situation in which the obesity treatment could actually lead to reduction in healthcare costs for diabetes or prevention of diabetes-related healthcare costs. But those studies are still lacking.
Thank you. Let me get a quick question out to Dr. Jensen. You told us about location predicting disease risk, but as well as measuring fat cell size and its ability to potentially have us understand more about regulation of body fat. Mike, can you tell us about measurements of fat cell size and how that could be drawn into the clinical setting since it still remains in the research setting?
Yeah, I certainly wish that we could get it in the clinical setting, but as you said, it's very few people want to have what we call a mini liposuction to have that done. Our goal, long-term goal, is going to be to see if we can assess parameters such as we've discussed, the fat distribution, sex, age, maybe things like that, to better understand what fat cell size might be without having to do the biopsy. So that our long-term goal is to try to put together some of the information that we're collecting that's easier to get to be able to predict whether you've got somebody who has a bunch of small fat cells or fewer big fat cells. And I think we focused in on the fat cell side just because it seems to be related to the metabolic, not so much the musculoskeletal problems.
Thank you. No other questions from the roundtable. Ms. Heron, you talked about, and thank you so much for your story about BMI, and it sort of just draw me back with your work with Oceans to think about BMI and how it's used in school settings. I was just curious how that was with, I think we try to, and I'm not a pediatrician or work in any way with schools, but I'm just curious how that is with BMI being used as a surrogate marker of health in schools, and if you could comment on that, and then also maybe how BMI can be used in a more patient-centric way, whether that might be in the clinical setting, as you had alluded to.
To your first point, I think what was frustrating for us was getting that information. And then again, my mom had no help in figuring out how to tackle that information. So again, what is the point of having that information if there's no evidence-based way to tackle that information? So again, I know BMI report cards, there's a lot of debate about that. And then again, if you're not going to pair that with some kind of evidence-based information, what is the point of providing that information in the first place? And then to your second point, BMI is one helpful tool that I've received in the clinic in one way, but in my most recent patient journey, other helpful tools I've gotten were body fat percentage, and then having my most recent blood work. So having a lot of tools was most helpful because I just went to the doctor yesterday and she said, we're not focused right now on getting you to a normal BMI because in my patient journey, I've never been in a normal BMI range. So I like, as a patient, having a lot of information in a lot of different ways, as we've talked about today. So I think giving patients as much information as possible, and then talking to them about realistic expectations for their care, and then talking about, moving next steps with that information to get to a healthy place.
Yeah, thank you. And actually just hearing you speak and thinking about the delivery of this information. I mean, we don't have a session today to talk about that, but it makes me think about who is actually delivering. And I think Dr. Caban-Martinez, you talk about the firefighters, and so this again is probably in a similar way, these report cards. And so you're having people who are non-medical giving medical information that is we're unable to interpret that at most levels, the person receiving that it is. So maybe anyone on the panel there, just to comment about that delivery of this information around BMI.
Yeah, I would just say really quickly that report back to community members in a study is really important. And what that information and how it's conveyed is even critical. It's an active area of research, understanding how best to report back information, particularly technical, medical, and laboratory information to a participant. I know with first responders that tend to also be emergency medical technicians and paramedics have a technical background, but even explaining the difference sometimes with like what's a median, a mode, it can be difficult, finding the right word choice on how to say. And I think as we think about reporting back to different communities about BMI and other areas of measuring body weight composition, that we are sensitive of how those participants and how those patients would like to receive that information and vet it with them so that it's clear what is being presented. Because oftentimes they'll just like scrap it up, tear it up and be like, I don't know what this means, and not make any utility of the information if it's not written in an accessible way.
Any others want to comment on that? Okay. Dr. Dietz.
Yeah, not on this topic, but coming back to Mike, is there a difference in the density of adipose tissue with small fat cells versus large fat cells that you could potentially detect by ultrasound?
Nice question, Bill. I think it's certainly possible. I've worked with some of the radiologists here, because some of the new ultrasound techniques are extremely high resolution, unfortunately also extremely expensive at this point in time. But they were reasonably optimistic that we could understand maybe some of the issues of fibrosis and vasculature, as well as maybe something about the adipocyte characteristics. But getting the money to do those studies proved to be quite an obstacle.
Yeah. I think we're coming up on 2:00. So we're going to take a short break to 2:15. I want to thank all the speakers today. Sorry? Thank all the speakers today, and we'll come back with our fourth session in about 15 minutes.